Another important cause for hemodynamic imbalance in the postoperative period is your RV dysfunction, particularly due to pulmonary hypertension. It is underappreciated, but it can lead to catastrophic effect. When the right ventricle pressure goes up, your RA pressure goes up, and there can be a opening of PFO, and there is going to be a right to left shunt, and the volume in the right ventricle, as the pressure goes up, tricuspid regurgitation can happen. As the right ventricle dilates, it pushes the septum towards the left side, and your left ventricle output is compromised. Your right ventricle output is compromised due to pressure overload, and by pushing the septum towards the left ventricle, your left ventricle output is also compromised, and you have decreased systemic venous return and decreased pulmonary venous return, and there is going to be increased intrapericardial pressure. So right ventricle, you have to be very careful in the post-operative period. The right ventricle with increased pressure overload assumes a spherical shape from the normal semicircular shape. By assuming this spherical shape, the cross-sectional area becomes larger than the left ventricle. Normally, the right ventricle cross-sectional area is lesser than the left ventricle, and they have a good demand supply. By assuming this spherical shape, the surface area increases and the demand becomes more. And by pushing the septum towards the left ventricle, it compromises the function of the left ventricle also. So what are your management goals, particularly if the right ventricle is involved? You optimize your volume status. You go for volume monitoring and try to reduce the volume as much as possible. Augment your right ventricle function. Reduce the right ventricular afterload. You reduce your pulmonary vascular resistance. That is going to be the most important goal. And you maintain adequate SVR. The goal is to keep your PVR well below SVR. This is the topmost goal for treating right ventricle. So your preload, you go for fluid restriction. If the fluid volume overload is there, you go ahead with loop diuretic or thiazide diuretic. And if at all the fluid is still high, you can try CRRT, also continuous renal replacement therapy. Early institution of this renal replacement therapy will go a long way to improve the outcome. Coming to reducing the afterload of the right ventricle, you can try nitroglycerin and go for prostaglandin E5 or prostacyclin, either in a intravenous or a inhalational route. Coming to the contractility of the right ventricle, dobutamine will be the first choice, and milrinone along with vasoconstrictor noradrenaline will be the second line of defense for increasing the contractility of the right ventricle. And most important thing to improve the right ventricle function is protective lung ventilation. You go with the low tidal volume ventilation. You try to minimize the inspiratory pressure as much as possible. It should not exceed 25 centimeter of water. Judicious use of PEEP. The more PEEP you give, more it causes pulmonary hypertension and more it affects the right ventricle. And optimize the oxygenation with increasing the FiO2 rather than increasing the PEEP. Finally, you target the PaCO2 to 30 to 35 millimeter of mercury with the pH greater than 7.4, slight alkalosis and low carbon dioxide.